keep on putting their fingers and constantly moving around, but those females affected with this kind of posture will be there, and that's a typical appearance of the disorder. So in this case, because male lethality, look at here, the female, and female. So it looks as if it's a female specific disorder, right? But it is an X-linked, I think. So it's an X-linked dominant disorder, but it doesn't look like that. The pattern is totally different, but because the male lethality happens. So if a pedigree is given to you like this, you should be able to determine whether it is X-linked dominant disorder with the male lethality. These are characteristic features of the Rett syndrome we just now talked about. They have got purposeless swinging or flapping movements in hands and arms, microcephaly, seizures are common, excuse me, mental deterioration, and that is because of the protein called gene methyl CpG binding protein. Okay? It's a gene methyl CpG binding, therefore it must be having modifications. It is an epigenetic modification. Okay? So it is just a protein which binds to the methyl CpGs. Because of that defect, you've got these issues. I think we talked about these. We don't need to go through step by step. Okay. Now, pseudo autosomal inheritance. In this case, male-to-male transmission also occurs. Again, it looks like an autosomal inheritance. One of these disorders is a dyschondrosteosis. There's skeletal dysplasia. So dysplasia means, what is that? This means different development. That's all it is. That is developing the developmental situation, skeletal abnormality occurs. That's why it's called skeletal dysplasia. So a greater prevalence of this disease is seen in females. Okay? The gene is a Hox gene, which is a transcription factor gene. So look at this. In this case, this is a proband, and the pseudo-autosomal region is the S or Y gene, right? Therefore, if it exchanges into X, it's a Y gene exchanging because of crossover. So it looks like, it looks very similar to any kind of a autosomal dominant disorder, but that is not the case. Okay? This is a pseudo-autosomal disease. Then mosaicism. We talked about X inactivation, that we're not going to go into details. So there is one disorder called segmental neurofibromatosis. We talked about neurofibromatosis before, that they carry on the skin spots called cafe ole spots. But here, those skin manifestations are not going to be uniform. That is, it will be patchy. There is some segments of the skin. In the neurofibromatosis, it's going to be very uniform. But here, some sections of the skin are patchy. Therefore, they're called segmental neurofibromatosis. This particular disorder, in this case, only limited to somatic cells. Okay, in some cases, there is limited to somatic cells, and it's called pure somatic mosaicism. In some cases, germlines it can happen, and therefore it's called pure germline mosaicism. It all depends on where it happens. Okay? For example, in females, you've got germlines. It takes about, from the time of zygote formation, almost like 30 divisions later, the germlines will start differentiating. Whereas in males, it takes a little bit longer time, longer divisions. So it depends on where the mutation occurs. Suppose if there is a cell which is from zygote, a cell is differentiating and came up to a point just before 30 generations, and you have a mutation there. Or if the mutation occurs after the germline started differentiating. So depending upon where the mutation occurs, you can either have a germline mosaicism. Suppose, this picture is not very clear what they have mentioned. If this is a zygote and it is dividing into multiple cell types here, and let us say that one cell, this is the cell which determines this is the germline. Okay? So now this is a germline cell. This cell is the one which is going to go and become testis or whatever. Yeah. If the mutation occurs here, random mutation occurs here, this particular thing is going to be germline mosaicism because the mutations are going to be different. Whereas if it happens elsewhere, you can have both germline and somatic mosaicisms. Okay? So it all depends on where the mutation occurs. So because of this kind of a scenario, finding mutations of mosaicisms is going to be very difficult. Because first of all, the tissue is going to be not accessible because it's a developing tissue. Okay? On top of that mosaicism, even mosaicism may exist in extra embryonic tissues. What are extra embryonic tissues? What are the extra embryonic tissues? Exactly, because a chorion, amnion, and other kind of tissues which are outside the proper embryo. And this also can happen. Mosaicism can happen there. Therefore, even if you access the tissue by some kind of going inside and aspirate the tissue, you still develop contaminations, and therefore, mosaicism, once it occurs, is very difficult for any kind of prenatal diagnosis or things of that kind. It's not trivial. Okay? That's what we're talking about. And somatic mosaicism exists in segmental neurofibromatosis, and therefore, if this fellow has an affected child, then the mutation occurred before germline and the somatic tissue separated. Okay? For example, here, this is demonstration of osteogenesis imperfecta here. This is a mutation in a collagen gene. This is the arrow here. Father is unaffected. But look at here, he came as a consultant. Okay, because whether he will have some other children will have a problem. That's why he came as a consultant. And these guys are affected. Therefore, what is the probability of this man having another child? What's the probability of getting the disorder? Because he's already having mosaicism, okay, germline mosaicism. Germline mosaicism means his children will be affected because the problem is there. But he will not be affected under any circumstances. But his children, therefore, the next any other child born to him will be affected. Okay? Usually, if it is a new mutation, recurrence risk is negligible. Suppose if there is a just simple mutation, is it going to reoccur one more time? No, it's pretty hard. Whereas if it is germline mosaicism, that recurrence risk is not negligible. So you will definitely get an individual in the family with the affected phenotype. We talked about this imprinting disorder, Prader-Willi and Angelman syndrome. Therefore, I'm not going to go through that. But there are some imprinting disorders other than Angelman and Prader-Willi. Those are extremely complicated and unusual pedigree. Okay? This is, what is it called? One of the disorders which is Albright hereditary osteodystrophy, where, look at this, these are metacarpals are very short, the distal phalanges are extremely short as well. Okay? So these are stunted completely. But that is usually the case. But on the other hand, there are disorders which are called PHP1A, PPHP, that is hypothyroidism and pseudo-hypothyroidism. So these particular cases, if you have this disorder, you will have obesity, etc. There's a phenotype. But if you have this gene, this particular disorder, along with this AHO with PHP, it's called PHP1A, you will have a defect in, what is it called, GNAS. The GNAS is nothing but alpha subunit of the S G protein. So this is another, but this is inherited from female only. Only if that happens, so this is a normal GNAS defect that will lead to AHO. But whereas if there is a defect in the female coming from the female, that will lead to a disorder which will have AHO plus PHP phenotype. That is called PHP1A. And whereas AHO alone and PHP1A, that GNASH is inherited from the male. So PPHP is a disorder they call it. So There is no AHO at all, no Albright osteodystrophy, but in the imprinting center, there is only a female copy of the GNAS, then you get PHP1B. So look at the complexity. Just because there is one disorder and there is another one coming from the maternal and paternal inactivations or so-called genome imprinting, your pedigree will look very, very complicated. Okay? This is the pedigree. We just now talked about various disorders. Look at here, female and male affected with the PHP1A. So those are affected with PHP1A. Whereas the female male affected with AHO, these are half bar, these are AHO. So AHO phenotype, PHP1 phenotype, and then PHP1B phenotype all mixed up here, and these are carriers. So what I'm telling is, this kind of a situation can happen and give you multiple disorders, one coming from paternal or maternal imprinting, the other one can be mixed up with the disorder, and that is why you have very, very complex phenotype here. Okay? So even if such pedigrees occur in your genetic counseling, you should be able to detect it because it has got pseudo hypothyroidism on the top of that, the so-called AHO situations. Now, we come to repeat expansions. There are repeat expansion disorders. Some of the disorders are also called anticipation disorders. And there are what are called CAG and CCG repeats. And these repeats, in every generation, they try to expand. Let us say there are only 10 copies of CAG. In the next generation, it can become 12 copies. Like instead of 10, it may have a 12, and subsequent generation, it may become 16, and so on. So that is because we'll talk about the slip mispairing later on in the next chapter, I think. More than 12 disorders are known with these repeat expansions. Most of these disorders are primarily neurological phenotypes. Some of them we will look at here. One is called Huntington. This is the dominant disorder where the CAG expansion occurs. In this case, this particular CAG is present in the coding sequence of the mRNA. And therefore, CAG codes for glutamine. Therefore, if you take a look at 35 repeats, and more than 40 repeats, you are going to have glutamine like that. So the protein will be expanded also. But in a fragile X-linked phenotype, you have got a CGG repeats, which expand, but that is present in 5' UTR. And there are almost like greater than 200 repeats and less than 60. Myotonic dystrophy, which is the dominant one, in this case a CTG repeat present in 3' UTR. What time is it now? 3 minutes, okay. Friedreich's ataxia is a recessive phenotype. This AAG repeat present in intron. Therefore, the location is not criteria. Okay. Some are present in coding sequence, some are present in 5' UTR, some are present in 3' UTR, some are present even in the intron. Nevertheless, these repeats will cause a disease. Okay. At least they have been correlated now to cause the disease. We don't know whether it causes the disease. There is a correlation of the disease with the repeat expansion. So if you take a look at the number of CAG repeats and the age of onset, so if you have less than 35 CAG repeats here, you will not have any kind of a disorder. Whereas if you are greater than that, let us say more than 36, so that's called fully penetrant range. So if you have a repeat of that kind, then you are going to get a particular disorder. Therefore, if somebody is having a repeat which is about, say, 30 or 25 or 30, and in the next generation, there's a possibility of expansion. Right? And therefore, you also go through anxiety issues as well in this particular disorder because you know that next generation or somebody will be affected, and these kind of situations will also be problematic for us. So this is an example of where you could use these PCRs to detect how many repeats an individual has.